Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident at the University of Pittsburgh, and this talk is going to be the first in our gynecologic cancer series. We're starting with an overview of cervical cancer. Cervical cancer is the fourth most common malignancy diagnosed in women globally, and it's probably the most common gynecologic cancer that affects women, again, globally. In the United States, it's not as common as endometrial cancer, just because cervical cancer incidence in the US is fortunately decreasing due to our use of screening with tools such as the pap smear, as well as vaccinations that are available for HPV. But it still does affect women, especially globally, especially in underserved countries where they do not have access to screening or vaccinations. The median age of diagnosis for cervical cancer is around 50 years old, so it tends to affect younger patients compared to those that we classically think about with endometrial cancer. Most commonly, around 80% of the time, the histology is going to be squamous cell carcinoma. And a major risk factor for this is HPV, or human papillomavirus, which is responsible for over 95% of these cases. The most common strains of HPV that are implicated are HPV 16 and 18, accounting for around 70%, but HPV 31 and 33 are also important to be aware of. So we'll divide our discussion on cervical cancer into two parts. In this first part, I'd like to focus on the presentation, workup, and staging, and then also a brief overview of the management of cervical cancer. In the next talk, we will actually discuss some of the evidence behind cervical cancer and some of the seminal trials that kind of guide our management of this disease. Let's start with some basics on the presentation, workup, and staging of cervical cancer. Oftentimes, cervical carcinoma might be asymptomatic and just detected on screening. And it's really important to be familiar with the screening guidelines for cervical cancer in the US. So the USPSTF recommends that women ages 21 to 65 should be routinely screened for cervical cancer. For ages 21 to 29, the recommendation is for cervical cytology alone every 3 years. So that's a pap smear every 3 years. For ages 30 to 65, they can certainly get a pap smear alone every 3 years, but they can also have co-testing with the high-risk HPV testing plus cervical cytology every 5 years. So that's an option as well. And then if they are over age 65 and they don't have any history of moderate or severe dysplasia, and if they've had 3 negative pap smears or 2 negative co-tests in a row, then they don't require any further screening at that point. So for ages 21 to 65, routinely recommend screening. And then above age 65, no further screening unless there are certain risk factors in their history. Now, we just said most of the time patients will be asymptomatic and it'll just be detected on screening. However, if the cancer is a little more advanced, then they might present with some symptoms. And so what could those symptoms be? Sometimes they can have abnormal vaginal discharge. They might have postcoital bleeding, dyspareunia, or pelvic pain as some examples. But again, because we have such a robust screening program in the US, a lot of the time these are going to be asymptomatic. Another thing to realize, and I guess this goes a little bit more with risk factors, but it's important to realize that HPV infection and therefore cervical cancer can actually be prevented by vaccination. There is a 9-valent vaccination available for children ages 11 to 12 years old with catch-up vaccination through age 26. And now actually adults ages 27 to 45 may also be vaccinated as indicated. So we have a vaccine, which is a way of preventing this infection and thereby preventing HPV infection and therefore protecting against cervical cancer. And so that brings us to the risk factors associated with cervical cancer. And as we just said, HPV is associated with over 90% of cases. HPV 16 and 18 are the most important strains to be aware of. They're associated with over 70% of cases. And then other cancer-causing strains include HPV 31, 33, 45, 52, and 58. But again, 16 and 18 are the most important ones to know about. And, as we just said, there is an HPV vaccine available. And so we're really trying to vaccinate as many folks as possible to try and prevent not just cervical cancer, but other HPV-associated cancers as well. Some other risk factors for cervical cancer, and a lot of times patients might have multiple risk factors. So it's important to be aware that some of these include smoking, immunocompromised status, young age at first intercourse, multiple sexual partners. So these are some just high-risk behaviors that can increase your risk of infection with HPV. Multiparity, lower socioeconomic status, and then another risk factor is diethylstilbestrol exposure in utero. That has also been associated with clear cell carcinoma of the cervix and vagina. So important risk factors to be aware of. Moving to anatomy, just for a brief review, remember that the cervix is located in the lower part of the uterus, and it's kind of a cylinder that's located at the bottom of the uterus, and it's right on top of the vagina. The cervix is, I think of it like a tunnel going from the inside of the uterus to the inside of the vagina, and the endocervical canal, so the inside of that tunnel, is lined by columnar epithelium. And then the outside of that tunnel, the part that's at the top of the vagina, is known as the ectocervix, and it's lined by squamous epithelium. So where those two different types of epithelium meet, the columnar versus the squamous, it's called the squamocolumnar junction, and it's located at the external os, which is the outside part of the cervix. So that external os, where that squamocolumnar junction is located, is actually the most common site for carcinogenesis, so right at that junction. So just keep in mind some of those terms about cervical anatomy, the internal os versus the external os, and that squamocolumnar junction. The other thing to keep in mind is that whenever cervical cancer spreads, one of the first places that it can go besides the vagina is to the attachments that help anchor it in the pelvis, right? And so one of those attachments is called the cardinal ligament. It's a ligament that actually attaches the cervix to the pelvic side wall. And when we use the word parametria, we're talking about all of the tissues that help hold the uterus and the cervix in place. And so the cardinal ligament is part of the parametria that actually attaches the cervix to the pelvic side wall. Other attachments to keep in mind that, again, make up the parametria include the broad ligament, which attaches the uterus to the pelvic side wall, and the uterosacral ligament, which attaches the low part of the uterus to the sacrum. So some of those ligaments make up what we call the parametria. That anatomy is important to consider when we're thinking about lymph node drainage, or if a cervical cancer arises, then through which lymph nodes would it drain? So one of the first places that it could drain through is through those surrounding ligaments that we just talked about. So the cardinal starts with a C, connects the cervix to the pelvic wall. The broad ligament starts with a B, connects think of the body of the uterus to the pelvic wall. And then the uterosacral connects to the uterus to the sacrum. So it's right in the name. So it can drain through those ligaments. It can also drain to regional lymphatics. So that includes the presacral, and it can drain through the uterosacral ligaments to the presacral nodes. It can drain to the obturator nodes, internal and external iliac nodes, and then eventually common iliac and upstream of that para-aortic lymph nodes as well. So all of those lymph nodes that are listed there are sort of the regional lymph nodes that are associated with cervical cancer. And then some of the common distant sites of metastasis include lungs, liver, and bones, which are pretty common for many other types of cancer as well. And with cervical cancer, we might also see supraclavicular lymph nodes. And the reason for that is because those can drain there via the thoracic duct. In terms of pathology of cervical cancer, the vast majority are squamous cell carcinoma. Because remember that cancer tends to arise right at that squamocolumnar junction, And so most of the time, these are arising from the outside of the cervix, and it's squamous cell carcinoma. And, somewhere in the neighborhood of 75 to 80% of cancers are squamous cell carcinoma. However, cervical cancers can also be other histologies. And if it's not squamous cell carcinoma, it's more than likely to be an adenocarcinoma or an adenosquamous carcinoma. So having that adenocarcinoma or adenosquamous carcinoma, it's less common, somewhere around 20 to 25% of the time, but it does confer a higher risk. These tend to be seen more commonly in younger patients. They present with larger tumors. You might see something called a barrel cervix, so just a larger tumor. These tumors tend to have higher risk of local failure, as we'll see in some of our evidence. And the Pap screening is less sensitive for adenocarcinoma, and so that co-testing with HPV actually helps improve our detection of these cancers. So majority are going to be squamous cell carcinoma, up to around 80%. Adenocarcinoma is going to be less likely. And then we can sometimes see even more rare histologies such as clear cell, small cell, neuroendocrine, sarcoma or rhabdomyosarcoma in pediatric patients, melanoma, and adenoid cystic carcinoma. In terms of workup for cervical cancer, we always want to start with a full history and physical. In this case, we would focus on gynecologic history, can inquire about vaccinations and things like that, obstetric history, sexual history, menopausal history. And then we want to obtain a complete pelvic and abdominal exam. Whenever we're doing this, we can also examine lymph nodes. We can examine the supraclavicular and inguinal lymph nodes, for example. But keep in mind that if disease is present in these lymph nodes, these are both distant sites of metastasis. Even the inguinal lymph nodes are not considered regional lymph nodes for cervical cancer. That would make it metastatic. So do that full workup. In terms of labs, we can always get a CBC, a CMP, consider HIV testing, and a pregnancy test is very important to consider, as well as a discussion about fertility sparing in women that are, that are of an age where we might consider pregnancy and fertility issues. In terms of procedures and obtaining pathology, so these are often done by the gynecologist. But one way to get pathology is to do a colposcopy with cervical biopsy, and this can also be called a LEEP procedure, so the loop excision procedure. That can be one way of obtaining a biopsy. If cervical biopsy is inadequate, then a slightly more invasive method is what's called a cold knife cone biopsy, where they actually remove kind of like a conical piece of cervical tissue. And cold knife cone biopsy is important to realize it can actually be a definitive treatment if cancer is early stage enough and if we're trying for a fertility sparing approach. So the LEEP procedure or the cold knife cone biopsy are two options. If patients have advanced disease, they might actually need an exam under anesthesia with cystoscopy and rectosigmoidoscopy to assess for bladder or rectal invasion of the cancer. Or, if we can already tell clinically that they have bladder or rectal extension present, it's really important to get that exam under anesthesia. And sometimes the cancer can be so aggressive into the bladder, it can actually press on the ureters, and patients might need ureteral stents. So these cancers can be quite advanced, and they can, invade into the bladder or the rectum. So that exam, assessing the full extent of disease, is really important, and that would need to be done under anesthesia. In terms of imaging, a pelvic MRI with and without contrast, as well as vaginal gel, is really important to delineate the local extent of disease. So the local extent of disease can be nicely assessed with a pelvic MRI, again, with and without contrast. The T2 weighted image is going to be most beneficial for us. And in the next slide, I'll show an example of what we might be looking for. But that really helps us to examine the local extent of disease, see if there's parametrial invasion and things like that, as well as if it's invading into the bladder or the rectum. A PET CT scan is going to help us with nodal and distant staging. So if lymph nodes in the pelvis light up on the PET CT, then that tells us that we have regional lymph node involvement. And it can also help us identify if there's any distant spread of the disease. So pelvic MRI with and without contrast, as well as PET CT, are really necessary for staging of these cancers. Other imaging that you might think about, which is allowed per NCCN, include chest x-ray, barium enema, skeletal x-ray, and intravenous pyelogram. So all of these can be included in our imaging, but the most important ones to think about, I would say, are the pelvic MRI and the PET CT. So let's take a look here at an example of a T2 weighted MRI. And as we said, T2 weighted MRI is really the best to visualize gynecologic cancers in general. So typically on a T2 weighted MRI, the cervix itself is going to appear hypointense, so darker compared to the rest of the surrounding tissues. And in comparison, the tumor will appear a little bit brighter, more hyperintense. Now, the way you can tell this is a T2 weighted MRI is if you look at the bladder, which is located just anterior to the uterus and the cervix, it's full of fluid. And on T2 weighted MRI, fluid appears bright. So T2, I remember H2O is what appears very bright. So here we see a T2 weighted MRI, and in pane A, we're looking at a sagittal section. In B, we're looking at an axial section. So on the sagittal section, you can see there's a lesion sort of intermediate intensity, I would say, and it's basically replacing the entire normal cervix, and it's invading into the lower segment of the uterus. If we look on the axial section, there's this nodular soft tissue extension that's those side arrows are kind of pointing at it in pane B. So the axial section is showing this nodular soft tissue extension that's indicative of parametrial involvement. So we wouldn't be able to see this level of detail and delineate these soft tissues as well on a CT scan. And so that's why that T2 weighted MRI is really important to help us with staging. And so finally, that brings us to the staging of cervical cancer. And I'm going to spend some time here because it's really important to be able to clinically stage patients. And the reason for this is that guides our management and how we treat these patients. So on board exams and in real life, it's really important to be familiar with the staging. For cervical cancer, the most recent system of staging that we have is the 2018 FIGO staging, and it divides cervical cancer into stages 1 to 4. Very simply, stage 1 is confined to the cervix. In stage 2, we're starting to invade beyond the uterus. In stage 3, it's more extensive with invasion of the lower vagina or the pelvic sidewall. Or we have regional lymph node involvement. So stage 3 can be a lot of different things. And then finally in stage 4, we're either invading into adjacent organs or we have distant metastases. So very simply, that's FIGO stages 1 through 4. Now, of course, on the RADONC boards, they're not going to ask it that simply. We have to get into the nitty-gritty details and understand the sub-stages of cervical cancer. So stage 1, confined to the cervix, is actually divided into two different stages, stage 1A versus 1B. Just remember that in stage 1A, we have less than or equal to 5 millimeters depth of stromal invasion. So 5 millimeters or less depth of stromal invasion. 1A1 is less than or equal to 3 millimeters, and 1A2 is 3 to 5 millimeters. But 1A is less than or equal to 5 millimeters depth of invasion. In stage 1B, we are now getting into more invasive depth of invasion, so greater than or equal to 5 millimeters depth of invasion. And then 1B1, 2, and 3 are based on the size. So 1B1 is less than 2 centimeters, 1B2 is 2 to 4 centimeters, and 1B3 is greater than 4 centimeters. But the most important delineation is in stage 1, 1A is less than or equal to 5 millimeters, and 1B is greater than or equal to 5 millimeters depth of invasion. If it's 2 to 4 centimeters, it's 1B2, and if it's greater than 4 centimeters, it's then 1B3. That is stage 1, and in stage 1, the cancer is confined to the cervix. In stage 2, the cancer starts to invade beyond the uterus, but it doesn't quite invade into the pelvic sidewall or the lower vagina. So in stage 2A1, we have invasive carcinoma less than or equal to 4 centimeters and extending beyond the uterus. And in stage 2A2, we have greater than 4 centimeter tumor that's extending beyond the uterus. So stage 2A, we're starting to extend beyond the uterus. 2A1 is less than or equal to 4 centimeters. 2A2 is greater than 4 centimeters. And then stage 2B is where we have invasion of the parametria, but not up to the pelvic wall. So 2B, we're starting to see that parametrial invasion. So it's starting to invade beyond the uterus, and it's actually involving some of those ligaments that are anchoring the cervix to the pelvic sidewall. So parametrial invasion is stage 2B, and that is really important to remember. Of all of the stages I've said so far, if you really remember any of them, I would remember that stage 2B is invading the parametria. That brings us then to stage 3. So stage 3 is invading into the lower 1/3 of the vagina or the pelvic side wall. So 3A is actually invasion into the lower third of the vagina without involving the pelvic side wall. And then in 3B, it's extending into the pelvic side wall. And remember we said that sometimes cervical cancer can be so aggressive it actually presses on the ureters and it can cause hydronephrosis and lead to kidney dysfunction. If that happens, so if you have a cancer that's so aggressive that it's either extending to the pelvic side wall or it's pressing on the ureters and causing hydronephrosis, that is considered stage 3B. And that's another very important one one of the most important ones that I would memorize is that stage 3B is pelvic side wall or causing hydronephrosis. So 3A is lower 1/3 of the vagina, 3B is extending to the pelvic side wall or causing hydronephrosis, and then 3C is if we have lymph node involvement. And 3C is divided into 3C1 versus 3C2 depending on which nodes are involved. So 3C1 is only involving the pelvic lymph node metastases, so the lower nodes in the pelvis that are closest to the cervix. 3C2 is more advanced, and so now we're moving north and we're actually getting some para-aortic lymph node metastasis as well. So pelvic nodes is 3C1 and para-aortic nodes is 3C2. And then finally, that brings us to stage 4. So in stage 4A, we're starting to invade into adjacent organs such as the bladder or the bowel. And you'll see in a lot of different cancers, stage 4A oftentimes is tumor that's so locally advanced, it's invading into nearby organs. So in the case of the cervix, it's the bladder and the bowel, which are, right adjacent anteriorly and posteriorly. And then finally, we have stage 4B, where we have spread to distant organs. So remember earlier we said even if we have like inguinal lymph node involvement or supraclavicular lymph node involvement, that would count as a stage 4B just because those are distant sites. Those are not considered regional lymph nodes. So that was a lot, but that is the staging, and it's really, really important to kind of memorize this because it shows up on exams, and then in real life, we need to have a sense of the stage so that we know how to manage these patients. One thing that came up when I was doing some practice questions that I'll share is risk of lymph node involvement and how that correlates to the stage. Very, very roughly, something you might be familiar with is the rule of 15s, and it just kind of corresponds to the risk of pelvic node involvement based on the stage. And the rule of 15s is just 15%, 30%, 45%. So a stage 1 cancer has a 15% risk of pelvic lymph node involvement. Stage 2 has a 30% risk of pelvic node involvement. And stage 3 has around a 45% of pelvic lymph node involvement. And then for any of those, the risk of para-aortic lymph node involvement would be around half of that. So stage 2, for example, if it has 30% risk of pelvic node involvement, would have around a 15% risk of para-aortic involvement. So that's just a basic rule that you might want to be familiar with, but these are very, very rough estimates. Most important things that I would remember from this staging section is 2B, we're invading the parametria, but not the pelvic wall. 3B, we are now invading the pelvic wall or causing hydronephrosis. And then 3A is if it's into the lower third of the vagina. 3C1 is involving the pelvic lymph nodes. 3C2 is involving the para-aortic lymph nodes. And then we have stage 4. And 4A is where you're invading into adjacent organs, such as the bladder and bowel. So this is hard. Staging is hard. It's something you just have to memorize. In practice, if you're not sure of anything, it's always prudent to look it up. But I think if you do it often enough, then you learn it really well. But for board exams, we do have to memorize these stages. So now that we have a sense of staging and workup, let's talk a little bit about the management of cervical cancer. So in a nutshell, you can think about localized cervical cancer in two groups. The first is early stage disease that might be amenable for a surgical approach with tailored adjuvant therapy, or it's locally advanced disease where the disease is so advanced that we actually don't do upfront surgery and we just treat them with definitive concurrent chemoradiation followed by a brachytherapy boost. So early stage patients are candidates for surgery, and if they have particular risk factors, we might offer adjuvant radiation or adjuvant chemoradiation. And then there are locally advanced patients where we would not even offer surgery as treatment, and we would just treat them with definitive chemoradiation followed by a brachytherapy boost. So 2 buckets for cervical cancer. Early stage patients that are amenable to upfront surgery, I have the stages listed there, 1A1, 1A2, 1B1, and 1B2, as well as 2A. But if you go back to the staging, the easiest way to think about it is tumor that is minimally invasive and just less than or equal to 4 centimeters. The earliest stage of cervical cancer is amenable to surgery. At the time of surgery, if we learn that they have particular risk factors, so when we look at the pathology after surgery is done, then there are particular risk factors for which we might recommend further treatment. So let's say they have surgery, and most of the time it's going to be radical hysterectomy, but we'll talk more in detail about the surgery. Most of the time they'll have radical hysterectomy and say they have that, and then there are risk factors. Certain risk factors would lead us to recommend adjuvant radiation. So for adjuvant radiation, we point to the SEDLIS criteria, which is based on a clinical trial that we will discuss in our next talk. But the SEDLIS criteria, very simplified, you just need 2 out of 3 of these criteria. So these risk factors are LVSI, or lymphovascular space invasion, deep stromal invasion, which is middle 1/3 stromal invasion or deeper, or tumor size greater than or equal to 4 centimeters. So if any of these risk factors are seen on pathology, these are indications for adjuvant radiation alone. If patients have more elevated risk factors or higher risk factors that fall under what are known as the Peters criteria, which is actually based on another clinical trial that we'll talk about in the next talk. These would be indications for adjuvant chemoradiation. So the Peters criteria are positive nodes, positive margins, or parametrial involvement, the 3 Ps. So SEDLIS criteria of LVSI, deep stromal invasion, and tumor size greater than or equal to 4 centimeters, those would be indications for adjuvant radiotherapy alone. And the Peters criteria, which are positive nodes, positive margins, or parametrial involvement, would be indications for adjuvant chemoradiation following surgery. So that is all for early stage disease, the earliest stage of cervical cancer that would actually even be amenable to a radical hysterectomy. For more locally advanced disease, so once we have either stage 1B3 disease, so clinically we can tell that the tumor is already 4 centimeters, or if there is invasion into the parametria or anything beyond that. Then we don't treat with surgery up front, and we just offer definitive chemoradiation with a brachytherapy boost. So chemoradiation consists of pelvic radiation to 45 Gray in 25 fractions, and we typically boost the involved nodes. And following the external beam radiation, which is given with concurrent weekly cisplatin, we'll actually follow up with a brachytherapy boost and treat the tumor that's in the cervix with additional radiotherapy, very, very localized using brachytherapy, and kind of boost the tumor that way. You might wonder, why don't we do everything with external beam radiation? Why can't we just give a big dose of external beam radiation and eradicate the tumor? Well, the reason is the cervix is located very close to the small bowel, which is very sensitive to radiation. And so we're not able to successfully treat to a high enough dose to the cervical tumor without blasting the bowel. And so the best way that we have found through clinical trials to successfully escalate the dose to the cervix without causing significant bowel toxicity is actually to do a brachytherapy boost. So this is a procedure where an applicator is actually inserted into the cervical cavity in the part of the uterus, and we treat with a radioactive isotope sort of very close to the tissue, which is what makes it brachytherapy. So that was a lot of information, and we're going to break it down a little bit and talk more in detail about the surgery as well as the radiation and chemotherapy considerations. But if, just to start this talk about the management of cervical cancer, think of it as 2 different buckets. So bucket 1 is early stage disease that's, tumor less than 4 centimeters and not extending into the parametria. These patients may be amenable to upfront surgery. And if they do undergo surgery, then there are certain risk factors for which we would do adjuvant radiation or adjuvant chemoradiation. And then for locally advanced disease that's greater than 4 centimeters or invading the parametria or more than that, then we would treat with concurrent chemoradiation and a brachytherapy boost. So let's talk about treatment a little bit more in detail now, and let's start with that bucket 1, those early stage patients that have disease that's less than 4 centimeters and no parametrial involvement. These patients may be amenable for treatment with surgery alone and then tailored adjuvant approaches depending on their risk factors. So with surgery, there are certain patients that might desire fertility-sparing approaches. Patients are only candidates for fertility-sparing if, first of all, they are able to have children. So if it's a woman that's premenopausal and is thinking about having children, and then the disease is early stage enough. If it's too advanced that we cannot offer fertility-sparing, then that's not even a question. So if a patient is considering fertility-sparing procedures, there's a couple of things we could do. So one of the things we could do is a cold knife cone excision. And remember, we talked about this as a potential biopsy technique where a large area of tissue around the cervix, like a cone-shaped lesion, is actually removed for pathology. Well, a cold knife cone excision can also be used as a treatment, assuming that, it's enough and the margins are negative and everything. So cold knife cone excision is one option for for a fertility-sparing surgical procedure if it's very minimally invasive. If it's too invasive for a cold knife, a radical trachelectomy is another alternative. And in a radical trachelectomy, we're removing the cervix, the upper vagina, and parametria, but the uterus is going to remain in place with a cerclage or a purse string stitch at the distal end to kind of keep that bottom part of the uterus closed and replace the function of the cervix. So a radical trachelectomy can also be considered if patients are really desiring a fertility-sparing procedure. So they'll remove the cervix, upper vagina, and parametria while keeping the uterus in place. Now, with these fertility-sparing procedures, it's important to make sure that we're doing an oncologic surgery and removing everything we want to remove. So after the procedure, it's important to evaluate the margins as well as the LVSI status. If the margins are negative and there's no LVSI, then we may pursue observation. But if there are positive margins and no LVSI, then a repeat cone biopsy or trachelectomy may be indicated. And finally, if there is positive LVSI, then a repeat trachelectomy with pelvic lymph node assessment, either via sentinel lymph node biopsy or lymphadenectomy, may be indicated. So it's important to realize that after these fertility-sparing procedures, the margin status and the LVSI is important to us. For patients that are not desiring a fertility-sparing approach, the standard really surgical management for cervical cancer is hysterectomy. And there's a few different types of hysterectomy to be familiar with. So a type 1 hysterectomy, which is also known as a simple or total hysterectomy, involves removal of the uterus and the cervix, but the parametria are left intact. A modified radical hysterectomy, which is a type 2 hysterectomy, removes the uterus and cervix as well as the upper 1 to 2 centimeters of the vagina and performs a wide local excision of the parametria. So a little bit more advanced now, we're removing upper 1 to 2 centimeters of the vagina as well as wide local excision of the parametria. In a type 3 hysterectomy, which is also called a radical hysterectomy, we're taking out the uterus and the cervix, a quarter to a third of the vagina, and the parametria are dissected to the pelvic sidewall or sacrum. So this is the most extensive of the three that are listed here, and it's really a radical hysterectomy that is needed for patients that are stage 1B1 or above that do not desire a fertility-sparing approach. So if patients have, greater than 5 millimeters stromal invasion, which makes you stage 1B1, these are the patients where radical hysterectomy is indicated. Additionally, we also need to address the lymph nodes, either via sentinel lymph node biopsy or lymph node dissection. So radical hysterectomy and sentinel lymph node biopsy or lymph node dissection for most patients with cervical cancer is what is considered standard. For patients that have less than 5 millimeters of invasion, so stage 1A disease, a modified radical hysterectomy may be acceptable, but if it's greater than 5 millimeters invasion, they really need a radical hysterectomy, and all patients should have lymph node evaluation. Now, one thing I want to note is that when we do surgery, we really only do it in the upfront setting for patients that have early stage disease. We are not routinely offering adjuvant hysterectomy because this has been studied, and we'll talk about it in our next lecture, but there's really no benefit in overall survival or disease-free survival with an adjuvant hysterectomy. So if patients are in that early stage bucket, that's the only time we would offer upfront surgery and kind of guarantee them to getting surgery. But if we're treating with definitive chemoradiation, then adjuvant hysterectomy is typically not thought about. The goal with surgery is typically to select patients that are at low risk for needing adjuvant radiation. There are times where patients will go to surgery and we will find information that we did not have on upfront clinical staging. And then in that case, we would offer them adjuvant radiation or chemoradiation as we discussed. But the goal is to try and select patients who are at low risk for needing these adjuvant therapies. The patients that do require adjuvant therapy are the patients that, if we knew about certain things before they went to surgery, we probably would have just treated them with definitive chemoradiation in the first place. I think that's an easy way to think about it, because in the SEDLIS criteria, we have size greater than or equal to 4 centimeters. In the Peters criteria, we have positive lymph node involvement and parametrial involvement. These are things that if we knew them before they went to surgery, we probably would have offered them definitive chemoradiation. But the fact that these criteria exist is just a testament to the fact that clinical staging is not always perfect, and sometimes we do find out more information at the time of surgery than we would have had just based on looking at imaging. So when patients are early stage clinically and then they go for surgery, the indications for adjuvant therapy kind of depend on certain factors that we look for. So remember, we talked about SEDLIS criteria, which are indications for adjuvant radiation alone. And a simple way to think of it is if they have 2 out of 3 of these factors. So LVSI, deep stromal invasion, or size greater than or equal to 4 centimeters. For adjuvant radiation and chemotherapy together, we use the Peters criteria. So if they have positive nodes, positive margins, or parametrial involvement, the 3 Ps of the Peters criteria, then we treat not just with adjuvant radiation, but also with concurrent chemotherapy. So what do we mean by adjuvant radiation? Typically, we're talking about pelvic radiation 45 to 50.4 gray at 1.8 gray per fraction. Sometimes in the postoperative setting, people will go to a slightly higher dose of 50.4 gray just because there's a thought that there might be some hypoxia in the postoperative tumor bed. And so the radiation is not working as well in that hypoxic environment. With our external beam fields, we're going to be covering the pelvic lymph nodes, including the common external and internal iliac, as well as the obturator nodes, and then the vagina and parametria. So at least 3 centimeters from the vaginal apex or 1 centimeters above the obturator foramen, whichever is lower. In some cases, physicians may consider adding a vaginal cuff brachytherapy boost in the postoperative setting. 2 or 3 fractions at 5 gray per fraction, 3 fractions perhaps if there is a positive margin, just to the upper 3 centimeters of the vagina. And this is considered by some if there are close or positive margins, or perhaps if a patient underwent an incidental simple hysterectomy rather than a radical or modified radical, if that was indicated. So that may be considered if needed. And then with the external beam radiation, we are giving, if it's indicated for those Peters criteria, we're giving concurrent weekly cisplatin, and the dose is 40 milligrams per meter squared. So that was basically early stage disease that was amenable for upfront surgery, followed by tailored adjuvant treatment. For patients that have stage 2A2 or greater disease, so anything that's greater than 4 centimeters, or if we know that they have parametrial involvement or beyond that, we treat them with definitive chemoradiotherapy. And with definitive chemoradiotherapy, we're treating pelvic radiation 45 gray and 25 fractions. Sometimes we will simultaneously boost the involved nodes to 55 to 57.5 gray. So that is called a SIB, simultaneous integrated boost. And with the external beam radiation, all of these patients, if they're getting definitive radiation, then they're getting definitive chemoradiation. So these patients should be getting weekly cisplatin, 40 milligrams per meter squared, unless there's some type of a contraindication to the cisplatin. So that's what we mean when we say definitive concurrent chemoradiation. And the external beam pelvic radiation is followed up with an intracavitary brachytherapy boost. And with that brachytherapy boost, we are aiming for a high-risk CTV dose to 90% of the high-risk CTV, or so we call that the HRCTV D90 of somewhere between 85 to 90 gray at minimum, if not greater. So that's a lot of information, and we're going to kind of break that down and talk about all of these different aspects of the definitive chemoradiation and brachytherapy boost. But what I will start by discussing is the importance of the technique when it comes to delivering external beam radiotherapy. There is a study called TIME-C, or it's also known as RTOG 1203 because that was the RTOG protocol. But TIME-C is also the name of this study. And they basically took patients undergoing pelvic radiation for different types of gynecologic cancers, so cervical as well as endometrial cancer. And they randomized them to receive 3D conformal radiation, so just a 4-field approach, APPA and 2 lateral beams, versus intensity modulated radiation. And the dose that these patients were receiving was somewhere between 45 to 50.4 gray. Nowadays, we just recommend 45 gray and 25 fractions, but remember we said there might be different indications to go up to 50.4 gray. So they compared 3D radiation to IMRT, and they found that there was a significant improvement in patient-reported GI and GU toxicity with the IMRT approach. And so for pelvic radiation, IMRT is really the preferred modality just because of decreased toxicity. And the TIME-C trial gave us some nice dose constraints that are good references for when we're doing our plans. And these also do show up in practice questions. So the small bowel recommended constraint was V40 less than or equal to 30%. The rectal constraint was V40 less than or equal to 80%. Bladder, V45 less than or equal to 35%. And bone marrow, the V40 was recommended to be less than or equal to 37%, and V10 less than or equal to 90%. So these dose constraints are important, and most importantly, the TIME-C trial tells us that when we're doing pelvic radiation for gynecologic cancers, IMRT is preferred, and we have level 1 evidence that it confers decreased toxicity compared to 3-dimensional radiotherapy. Now, remember we said that in order to eradicate cervical cancer, we need to get to a pretty high dose. So if we're thinking about equivalent dose at 2 gray per fraction, we need to get to a dose of somewhere around 85 to 90 gray in order to successfully cure the cervical cancer. It's really difficult to get to that level of a dose using external beam approaches. And there have actually been investigations looking at boosting it with external beam approaches, including SBRT techniques. And it turns out that none of those approaches are nearly as effective as treating with brachytherapy boost. So the rationale for a brachytherapy boost is that we treat the entire pelvis and we sort of sterilize the pelvic nodes that are at risk of involvement. And we get to a certain level of dose, 45 gray and 1.8 gray per fraction, to the pelvis and to the cervix. We then do a brachytherapy procedure to internally treat the cervix and boost it to a higher dose. And because of the physics of brachytherapy, because we're inserting a radioisotope that is much lower in energy compared to the MV photons that we're using for external beam treatment, the dose fall off is much sharper. And so we're able to really nicely target the cervix and get to really high doses inside of the cervix while sparing our normal tissues, especially the small bowel. And so that's really the rationale for a brachytherapy boost. Now, historically, brachytherapy for gynecologic cancers was performed using a 2D planning approach, also known as point-based planning. So there was one system of brachytherapy called the Manchester system, and they actually prescribed a dose to a particular point within the cervix. So they inserted an applicator, and usually with cervical cancer, the applicator that we're using for brachytherapy is a tandem, which is a long stick that inserts inside of the uterus. and then to get some more dose into the area that's around that bottom part of the cervix, we insert either something called ovoids or a ring that sits at the base of the cervix. And so the ovoids and the ring help us to get more dose just to where the cervix is. And then the tandem helps us get really inside the cervix. So you put in this applicator, either a tandem and ovoid or a tandem and ring, and you take a film, just a plain, an X-ray, and you can see that applicator is in place. Point A refers to a point that is 2 centimeters superior to the external cervical os and 2 centimeters lateral to the midline. And that point is where we prescribe the dose. So basically, they were, blowing up the dose in a circle that corresponded to a radius of where point A is. And everything inside of that circle was getting the prescription dose. There's also point B, which is 2 centimeters superior, but then 5 centimeters lateral to the external cervical os. But point A is where they were prescribing the dose. And this was a very simplistic approach. And what we've now learned is we can do 3D planning rather than 2D planning, and we can actually prescribe our dose to a volume rather than just to a point. And with that 3D planning approach, it helps us to kind of better target the tumor and really target where the tumor is located. And theoretically, it should also help us with sparing our organs at risk and causing less toxicity. So enter the 3D era of brachytherapy planning, which is what a lot of centers have moved to. In 3D volume-based planning, we actually insert an applicator and then we obtain either a CT scan or an MRI, and we draw out our volumes on that image, and then the plan is made so that our dose is prescribed to a volume. The volume that we prescribe our dose to is known as the high-risk CTV or the HRCTV. And that is a more accurate way of ensuring that the tumor is getting the target that we want to treat, which is the tumor, is getting an adequate amount of dose. And it also helps us to draw out our organs at risk, including the bladder, the rectum, the sigmoid, and better protect them. And there's actually evidence that using 3D volume-based planning improves local control and disease-free survival outcomes compared to the point-based system. There is a series of studies that you should be familiar with, including these are called the EMBRACE studies, and they are, prospective observational studies of patients treated with MRI-guided adaptive brachytherapy. The advantage of using MRI for brachytherapy planning is that we can better delineate not only the tumor, but also the organs at risk, and it's better for brachytherapy treatment planning just because we can see things a little bit better than on CT. That said, CT is also miles ahead of, just the 2D planning where we're prescribing dose to a point. So we will talk about the EMBRACE studies more in detail in the next talk. But what you should know is that the EMBRACE 1 study is a prospective observational study of chemoradiation and MRI-guided adaptive brachytherapy. And they found very good local control, so 92% 5-year local control and a 67% overall survival for stages 1 through 4 cervical cancer, with minimal grade 3 to 5 toxicities, somewhere in the neighborhood of around 7%. The retro EMBRACE studies was based on a retrospective data, but they actually derived a dose-volume relationship of tumor control probability, and they showed that the larger the tumor, the less the likelihood of local control, which makes sense. And they also showed that if we cover our high-risk CTV with at least 85 gray, so when we say cover our high-risk CTV, we're really talking about the dose to 90% of the HRCTV. That's called the HRCTV D90. If we cover that with 85 gray, and that again is an equivalent dose in 2 gray per fraction. So we take our brachytherapy fractionation and we convert it using radiobiological equations, and we combine it with the external beam radiation dose, which was 45 gray and 1.8 gray per fraction, an EQD2 of 85 gray for the HRCTV D90 is correlated with superior local control. So that came from retro embrace. And then we also have embrace 2, which is a prospective observational study using not only image-guided adaptive brachytherapy with MRI planning, but also IMRT and IGRT in this modern era. And it's kind of prospectively validating these embrace findings, and their protocol is really excellent for detailed DVH constraints for both the external beam as well as the brachytherapy treatment. So the embrace studies are really kind of the cutting edge of brachytherapy treatment planning, and they're really good resources for us when we're making treatment plans in clinic. So just to give a sense of what brachytherapy boost doses look like, after undergoing the 25 treatments of pelvic external beam radiation with the concurrent chemotherapy, patients will come in for their brachytherapy treatments. And typically it's just a handful of treatments, somewhere in the neighborhood of 4 to 6 treatments. And the guidelines from American Brachytherapy Society were published back in 2012, and they give us some good dose fractionation regimens to think about for the brachytherapy boost dose. So example doses include 6 gray times 5 fractions, 5 gray times 6 fractions, or 7 gray times 4 fractions. And when we're calculating our HRCTV D90, what we do is use radiobiological equations to convert it to an equivalent dose in 2 gray per fractions. And when we do that, what we're aiming for is that at least 90% of our HRCTV is receiving at least 85 gray, if not higher. At the time of brachytherapy planning, in addition to thinking about the dose to 90% of the HRCTV, and I should note that it's also recommended to consider the dose to 98%, but HRCTV D90 is what came out of the retro embrace trial, and so that's why I'm kind of emphasizing that 85 gray minimum. So we can look at a few different things, and we can also contour the GTV if we actually see residual tumor, and we can tailor the dose to the GTV as well and make sure that it's getting a really high dose. But in addition to looking at those things, that's just the kind of the coverage of our target volumes. We also need to be careful about our organs at risk. And so the Embrace 2 protocol has some nice recommendations for constraints in our brachytherapy planning. And these are all as well in equivalent dose at 2 gray per fraction, assuming an alpha beta ratio of 3. So the planning aims are really soft constraints recommended by the Embrace 2 trialists, but these planning aims are typically what we aim for just because they have hard limits as well that are a little bit more generous. But the soft constraints are more, I would say, what we try to aim for when we're doing these treatment plans, just because we do not want to cause patients severe toxicity. And it can be severe, such as fistula, for example. So the soft constraints are for rectum, the dose to 2 cc's of the rectum should be less than 65 gray. The D2cc to the sigmoid should be less than 70 gray. For the bladder, D2cc should be less than 80 gray. And then for the rectovaginal point, the recommendation is less than 65 gray to minimize the risk of vaginal stenosis. So these are sort of the soft constraints. If needed, and if you're really in a fix, you can go a little bit higher on these constraints, and as long as you're not exceeding the hard constraints. But again, as I said, I think we try to aim for those soft constraints. 65, 70, 80 D2ccs to the rectum, sigmoid, and bladder whenever possible. The last thing I will point out is that when it comes to cervical cancer, especially, it matters for all cancers, but especially for cervical cancer, total treatment time really matters. So we aim to not exceed 8 weeks, so absolutely no more than 56 days between the start of our chemoradiotherapy and the end of our brachytherapy. Each day of treatment prolongation beyond 8 weeks corresponds to a decrease in local control of anywhere between 0.5 to 1%. And if there are delays, then you can actually add more fractions to kind of make up for that lost time. But it's really important to realize that if there are a lot of treatment breaks and if we are interrupting patients' radiotherapy, then it does actually lead to a worse local control. So the treatment package time matters, and we don't want our total treatment time to exceed more than 56 days. And that number, 56 days or 8 weeks, is based on retrospective data that showed an increased risk of pelvic failure if the total treatment time is more than 56 days. In retro-embrace, they actually found that local control was worse if treatment time was over 7 weeks. And so in Embrace 2, they're actually recommending that the overall treatment time should not exceed 49 days or 7 weeks. And so you might hear either number, 56 days or 49 days, but keep in mind that we try to finish all of our treatment within 6 to 8 weeks. Each week that we increase the total treatment time, we actually need to prescribe an additional dose of 5 gray to make up for that loss of local control. And so you really want to avoid treatment breaks whenever possible. And for this reason, oftentimes brachytherapy boost might even be started by the middle to the end of the external beam radiation course. So there may be some overlap. The patient probably wouldn't have both treatments on the same day, but there might be some overlap. They might have 1 day break in their external beam so that they can actually get started with the brachytherapy boost portion. So total treatment time is really, really important. So let us just quickly recap what we talked about in our management overview. Remember, we talked about 2 buckets of cervical cancer. So the first is early stage cervical cancer, less than 4 centimeters, no parametrial involvement. Most of the time, these patients are going to get radical hysterectomy. So if they have greater than or equal to 5 millimeter stromal invasion, radical hysterectomy is typically the surgery of choice. And in certain cases, patients may need adjuvant therapy, though we try to select for patients that won't. Indications for post-op radiation alone are the SEDList criteria, which are tumor size greater than 4 centimeters, deep stromal invasion, or LVSI, and you need at least 2 out of 3 of these for post-op radiation. If patients have any of the 3 Peters criteria, so positive margins, positive nodes, or parametrial involvement, then they would need post-op chemoradiation. So that is sort of the upfront surgery followed by tailored adjuvant approach for early stage cervical cancer. If disease is greater than 4 centimeters or if there's parametrial involvement, then right away, or if it's more extensive than that, we know that we're not going to do upfront surgery, and instead we're just going to treat with concurrent chemoradiation followed by a brachytherapy boost. And that concurrent chemoradiation is 45 gray and 25 fractions to the pelvis with concurrent weekly cisplatin, 40 milligrams per meter squared, followed by a brachytherapy boost, something like 28 gray and 4 fractions, for example. And then when we calculate the equivalent dose in 2 gray per fraction for the brachytherapy boost plus the external beam radiation, our target HRCTVD 90 is at least 85 gray based on the Embrace data. Now, in the next talk, we will talk about get into the evidence for all of this, including the trials from which we got the SEDList criteria, the Peters criteria, and we'll talk about, more in detail about the Embrace trials as well. Hopefully this was a helpful overview of cervical cancer and some of the important considerations for management. And in our next talk, like I said, we will shed some more light on the evidence. Thank you so much for your time and attention.